Assalamu alaikum, everyone. It is my distinct honor and pleasure to be invited to speak at PSH 2021 on a topic of great importance, which is COVID-19 vaccine update. Let me share my screen with you. So over the next 20 minutes or so, I'm going to talk about the current vaccine landscape, vaccine effectiveness in general and certain special populations, and then talk about vaccine effectiveness against variants of concern. We will talk about the importance of Delta variant in the current landscape, and then we'll finish off with waning immunity and the need for a third dose of vaccine or a booster dose. So let's start off with the current vaccine landscape. There are more than 100 vaccines that are in various phases of clinical trials right now. 13 have been authorized for use in one or more countries, and 8 vaccines have been approved by the WHO for widespread use against SARS-CoV-2 infection. The first 2 vaccines to be approved were based on mRNA technology, and these were the Pfizer-BioNTech and Moderna vaccines. We also have the Janssen and Oxford AstraZeneca vaccines, which use a non-replicating viral vector. And then we have Sinopharm and Sinovac, which use inactivated virus as the platform for vaccine. This slide gives you an overall view of vaccine efficacy in clinical trials. For the Pfizer and Moderna, the vaccine effectiveness or efficacy has been about 95% or so. With the Johnson & Johnson vaccine, it was 71%. For AstraZeneca, 62 to 90% based on which population, which dose, and which dosing interval you looked at. For Sinopharm vaccine, it is 72 to 80, 85% or so. Sinovac had a little bit of a setback, perhaps because of specific variants that were occurring in that population where they studied, and they reported a vaccine efficacy of only 51% or so. The Russian vaccine, the Sputnik, has reported the vaccine efficacy of 92%. I will not go into the details of clinical trials which showed the efficacy, but I will share with you 1 or 2 slides about vaccine effectiveness in the real world. This is a study we conducted in a very high-risk population, which was significantly older and with a very high burden of comorbidities. We looked at over 100,000 people overall, and we found that the vaccine effectiveness 7 or more days after the second dose was 97.1%. However, the caveat was that this study was done before the advent of the Delta variant. These are some of the details of this particular vaccine effectiveness study, which we published in Annals of Internal Medicine a couple of months ago. And when you compare Moderna versus the Pfizer vaccine, there is no significant difference between the 2 vaccines in terms of its effectiveness, in terms of their effectiveness against any confirmed infection. There is a slight benefit in people who are less than 70 years old and those who have a lesser burden of comorbidities, but this difference is so small, and the overall vaccine effectiveness is in the range of 96 to 97% or so. So this difference probably is of no clinical relevance at this point in time. Let's talk about the variants of concern. And variants of concern are so named because these new variants have either reduced vaccine effectiveness, or they have a higher level of infectiousness or poorer clinical outcomes. Like all other RNA viruses, the SARS-CoV-2 virus also mutates over a period of time if the propagation in the population continues, and these variants emerge. Ever since we started seeing the variants, which are now named after the Greek alphabets, alpha, beta, delta, and so on and so forth, we started looking at vaccine effectiveness against the new variants. And we published this key study in the New England Journal of Medicine a few months ago, where we looked at both infection as well as vaccine effectiveness against severe and critical disease for both alpha and beta variants. And we found that for any infection, the vaccine effectiveness against the beta variant was significantly lesser than that for the alpha variant. However, overall vaccine effectiveness against the beta variant was still about 75%, which is very good. For the alpha variant, this was about 89.5%. But when we looked at severe and critical disease, the vaccine effectiveness against both alpha and beta variant was 100%. So this was very reassuring that even though people may get infection, the vaccines are highly protective against severe and critical disease. even against these new variants which are developed at that point in time. We also looked at these in different ways and at different points of time after the vaccines were given. And it seems like the protection is maximal after about 14 days of the second dose. And that is why we measure vaccine effectiveness as a standard 14 days after the second dose of these mRNA vaccines. These are the same data which are presented in a different format. And you can see that protection against any severe, critical, or fatal disease is about 96%. So these vaccines are highly effective against severe or critical disease against both alpha and alpha and beta variants. While we were getting comfortable with the high level of vaccine effectiveness against alpha and beta variants, along comes the delta variant. And why is there so much hype about delta, and why is it so important in the current landscape? Well, it turns out that it is approximately 60% more infectious than alpha, and it has an R0 of between 5 and 8, as compared to between 2 and 3 for the earlier variants. Now, why does this matter so much? Because in a non-vaccinated population, if you have a virus with an R0 of 2.5, after 10 cycles of transmission, you can expect about 9,500 cases. In the same non-vaccinated population, a virus with an R0 of 6 after 10 cycles of transmission can lead to more than 60 million cases. So that is why this Delta variant has become predominant in almost every country where they are measuring the predominance of various variants of concern, particularly the Delta variant. Now, Delta variant is also associated with more severe infection, as we show in this study, which is in peer review right now. And this difference is more stark against severe and critical disease. In this particular study, we looked at outcomes in Delta versus the beta infection. And remember, beta infection itself was associated with slightly more severe disease than the alpha infection. So among unvaccinated adults who have Delta infection, the risk of severe or critical disease is about 5 to 6 times higher than comparable people who have beta infection. The difference is less marked for mild to moderate disease, but for severe and critical disease, this is a major difference in terms of outcomes between vaccinated and vaccinated people. Now, we looked at both mRNA vaccines, the Pfizer and the Moderna vaccine, against confirmed infection, asymptomatic infection, symptomatic infection, and severe critical fatal disease caused by the Delta variant. And as you can see from this slide, that there is a significantly reduced vaccine effectiveness against all outcomes except severe and critical or fatal disease, compared with what we have historically seen against the earlier variants. So for the earlier wild type variant, the effectiveness was about 95 to 97%. For the Delta variant, this is about 52 to 73% or so. However, what is reassuring is that effectiveness against severe, critical, or fatal disease is still well above 90% or so. So this gives us a lot of hope that with enough vaccination, we can have a decent control against even the Delta variant. Let's move on to certain special populations, and let me start with vaccine effectiveness in pregnancy. And again, I must preface that with the caveat that this is before the Delta variant became predominant in the world. We looked at over 4,500 pregnant women, and we determined the cumulative incidence and determined the adjusted vaccine effectiveness in pregnant women. The cumulative incidence was significantly higher, about 7 to 8 times higher among unvaccinated pregnant women compared to those who were fully vaccinated. And this translates to a vaccine effectiveness of about 87% or so. So this vaccine is highly effective in pregnant women, regardless of the trimester of pregnancy that the vaccine was administered, although most of the vaccines were administered in the first or second trimester in our population. Chronic hemodialysis is a special population as well, because people who have renal failure and are on long-term hemodialysis have consistently low levels of antibody after receiving vaccination. And this turns out to be the case when we look at vaccine effectiveness in these patients as well. So we looked at 850,000 people who were tested between January and August. So some of these people do have the Delta infection. And we found that 14 or more days after the second dose, the vaccine effectiveness is about 68%. Again, this is significantly lower than in non-hemodialysis people, which is well above 90% or so. There is no significant difference between the Pfizer versus the Moderna vaccine in this population. We also looked at patients with inflammatory bowel disease. This is also a special population because these people are immunosuppressed because of their IBD, but also because they are immunomodulators and biologic agents. It turns out that protection or vaccine effectiveness against documented infection was still quite high, which is about 91% or so. And protection or vaccine effectiveness against hospitalization or severe or critical disease also was very high, about 93% or so. The number of people on immunomodulators was relatively small in this study that we conducted, but we did not find a major signal of reduced effectiveness in people who were on immunomodulators or biologics. We also looked at the vaccine effectiveness in kidney transplant patients. Here we did not calculate V in terms of percentages, but we looked at cumulative incidence over a period of time at various time points after the vaccination was given. So whether you look at 14 days after the second dose, 42 or more days after the second dose, or 56 or more days after the second dose, the difference between vaccinated and unvaccinated group remains very starkly different, suggesting that there is a high level of protection against infection in patients who have received a kidney transplant. So let's move on to the big question these days, which is that of waning immunity over time. And is there a strong case for giving a third dose to everyone? So we have this Sentinel paper, a major paper, which was just accepted in the New England Journal of Medicine once again. And we looked at the effectiveness of the Pfizer BNT162b2 vaccine at monthly intervals after the second dose of the vaccine. And we looked at any infection, and we also looked at severe, critical, or fatal disease. And as you can see from the graph on your left-hand side of the screen, that the vaccine effectiveness wanes very significantly after about 3 to 4 months or so against any infection. However, when you look at severe, critical, or fatal disease as an outcome, the vaccine effectiveness is still there for about 6 months or so, and only after 6 months does it start to drop in any significant or meaningful manner. This observation is also borne by in vitro studies, where people have looked at neutralizing antibody response after 2 and 3 doses, and people have looked at the wild type versus the beta variant, and wild type against the Delta variant. So the results for the beta variant are on the left side of the screen, where you can see with the red arrow that after getting the third dose, the neutralizing antibody titer significantly went up. And this was true for younger people as well as people who were more than 65 years of age. On your right-hand side on panel B, you can see the response in patients with the Delta variant. And again, there is a significant increase in the antibody titers after the third dose, which again, based on the fact that third dose may be inducing a robust immune response in these people, both younger people as well as older people. Early reports from Israel also confirm this in an actual real life situation, where they have found that the incidence in people who got a booster was significantly lower compared to those who did not receive a booster. And the difference in the risk is for confirmed infection is about 11-fold. In other words, about 1100%. So 11 times more infections in people who did not receive a booster. While the risk for severe or critical illness was even more dramatically different. There was a nearly 20-fold or 20 times difference in people who received a booster versus who did not receive a booster. So taken together, this strongly suggests that a booster dose would induce immunity both in terms of neutralizing antibody response as well as in actual prevention or protection from infection and from severe disease. These are the same data from Israel, which look at the difference between the two groups. And you can see that days after the booster vaccination, the difference in the two groups starts going up very significantly. And the overall difference about 15 to 20 days after the third dose are about 24 difference in the two groups. Now, is there any additional evidence to support this? And I think that various countries who have had high rates of vaccination and a very good level of testing, and this is indirect evidence to support that. So if you look at two countries, Singapore and Israel, these are countries who have very, very high rates of vaccination and who were also very proactive in terms of mask mandates and general protective measures, at least early on in the pandemic. And they also were the first countries to reach, among the first countries to reach very high levels of vaccination for the population. So if you look at Singapore on the left-hand side, about 77% of their population is fully vaccinated. And after the vaccination, you can see they had a very low level of infection in the early parts of 2021 when the vaccination rate picked up. And of course, this was also complemented by very strict public health measures. But once the Delta variant came in, and when people were about 6 to 7 months out from vaccination, in August, they started to have a significant rise in infections in the country. Same is true for Israel in some matter. Their vaccination rate was not as high as Singapore or Qatar for that matter, but they were one of the first countries to achieve a high level of vaccination in the country. And in April and May, their rates of infection went down dramatically, which is largely attributable to the vaccination effect. But again, in August, they started having a significant rise in infection, a dramatic uptick of overall infection rate. They had two things going against them. So one was that the vaccine protection was waning over a period of time because they started very early. But they also relaxed some of the public health measures, for example, masking mandates and physical distancing. As opposed to Qatar, which also saw a small rise in April for the beta variant, but we haven't seen that major rise with the Delta variants thus far. Qatar is among the countries with the highest vaccination rates in the world. Over 80% of our population is fully vaccinated at this point in time. So how do you put all these data together and make some sense out of this? Well, it is abundantly clear that vaccines are highly effective against preventing infection and even more effective in preventing severe or critical disease and preventing death. It seems that immunity does wane over time in a large segment of the population, and booster dose seems to help significantly. However, the optimal booster strategies are still being worked out. I will finish off with a few frequently asked questions that I get all the time from different people, and then we'll open the session up for questions from the audience. Well, the first question, and believe me, there are still some people who ask that should I get vaccinated because they're not very convinced. Well, this shouldn't even be a question at this stage. There are ample and abundant data that vaccination is extremely beneficial, not just for the individual, but for the population at large. The second question, which I get all the time, is which vaccine should I get? And my answer still is what I said about 6 months ago. Whichever you can get at this point in time, whichever approved vaccination that you can get hold of, you should get. But my feeling is perhaps mRNA vaccines are a little better and more accepted globally for travel. So if you have a choice, then I personally would go for one of the mRNA vaccines at this point in time. Third question is, I've received the Sinopharm or Sinovac vaccines in the past. Can I take an mRNA vaccine now or a different vaccine now? So this is the concept of heterologous vaccination. And my general answer to that is yes. In terms of science, yes, this is a reasonable thing to do if 3 or more months have passed from your last dose of your last vaccine. However, this has to be looked in the context of public health and policy debate that If you have a very limited supply of vaccine, then most of your population is not has not received 1 or 2 doses. It might be more useful to give them the first and second dose than giving a third dose to a small segment of the population. Another main question is, I missed my second dose of a two-dose vaccine. Should I start all over again? My answer to that is, if it has been less than 3 months or so, just get the second dose. There's no need to start the clock again, but then consider the second dose perhaps 6 or more months later. The next question is that I have taken 2 doses. Should I take the third dose? And I've shown you some convincing evidence that yes, unless there is a contraindication or there is a shortage of vaccines in the country, or if the population that you live in has very low level of overall vaccination, then it makes good sense to get the third dose. If I qualify and if there are enough doses for the third dose, when should I take it? And again, this is still being worked out, but my general feeling is that based on our data and some other data that I've shared with you, that perhaps 6 or 7 months after the second dose is a good time to take the third dose, unless you are significantly immunocompromised, in which case you may consider taking it perhaps after 4 months or 5 months or so. I will stop here, and I'll be happy to take any questions from the audience at this point in time. And I would also like to thank the organizers, the president, the secretary, and the scientific committee of PSH for inviting me for speaking at this wonderful conference. Thank you.